How do you treat pyloric stenosis? So you have that 5-week-old baby, projectile, non-bilious emesis, comes in the ER, is crying, really upset, super hungry. How do you make the diagnosis and initiate treatment and then decide when they're safe to discharge home? We're gonna go through all this today at Citizen Surgeon. Let's do it. Welcome back to Citizen Surgeon. I'm so pumped that you're here. We're gonna get you comfortable on the wards, in the ICU, in the operating room, and of course, we're gonna crush those exams. Today, we're talking about hypertrophic pyloric stenosis. I put out a survey. I asked you guys, what do you wanna learn? And you told me you wanted to go through some pediatric surgery topics. So we're gonna start it off with a good one. This is a common thing that I'm seeing down in the ER. I'm working with these babies, I'm talking to these parents, and so this is right in my strike zone. So we're gonna have an awesome talk today. So I want you to consider this clinical scenario. You have a 5-week-old Caucasian boy that was born at 35 weeks to a P1G1 19-year-old mom, okay, who comes in with projectile non-bilious emesis over the last week. You're thinking in your mind, gosh, I think this could be pyloric stenosis. Well, what are the features of the history and exam, and what are the diagnostic tests that we need to do to confirm that diagnosis? Well, first I should tell you, well, what is hypertrophic pyloric stenosis? So, hypertrophic pyloric stenosis, we'll call it HPS. This is where you get hypertrophic growth of the muscular layer of the pylorus. So I have this illustration of a stomach here, and you can see at the gastric outlet, we have the pylorus, and this helps regulate flow of gastric contents into the duodenum. Now, in the muscular layer, we have the circular muscle, we have the longitudinal muscle, and in HPS, hypertrophic pyloric stenosis, we get hypertrophy or growth of that, usually the circular muscle layer. That creates a real thickness at the pylorus so that gastric contents cannot leave the stomach. And that's why you get this really forceful non-bilious emesis. Now, before the 19th century, this was almost universally fatal. But after the 19th century, we're going to talk about a couple of surgeons that came up or evolved a solution to this problem, and since that time, a very safe treatment pathway has been established, and these babies come in the hospital very sick, but leave to relieved parents with a very low-risk treatment plan. Now, the first person to describe pyloric stenosis was at autopsy, and this was Patrick Blair back in 1717. And he described the pylorus and the duodenum being cartilaginous, almost ossifying or becoming bone-like because they were so firm from this hypertrophied muscle. After this, and I want you to check out this paper. This was an awesome paper talking about the history of pyloric stenosis and the surgeons that really changed how we approach this condition and led to the saving of thousands of babies, and over the course of time, hundreds of thousands of babies' lives. I'm sure it has to be, the numbers have to be up there because this is a pretty common problem, as you're going to find out. So after this observation, several surgeons were involved. Heineke and Mikulec, who are famous for eponymously the Heineke-Mikulec pyloroplasty, they opened the pylorus longitudinally through the entire wall, through the mucosa, and closed this transversely. But it wasn't until Ramstead did the pyloromyotomy in a child that he couldn't actually close it transversely with the sutures that they were using at the time. He just left it open, dividing the serosa muscular layers, but leaving the mucosa intact. And today, 150 years or so later, we still use a version of that same operation that he evolved back in the 19th century. So the history in pyloric stenosis is fascinating. Let's get into the epidemiology. So how common is this? So it usually happens in the age group of 3 to 5 weeks of age, okay? Very rare after 12 weeks of age. We see this at about 3 per 1,000 live births. The males have it more common than females, about 5 times more common. It's more common in children who are born in a preterm birth, if it's the firstborn infant, and in infants that are born to younger mothers. What are the causes of pyloric stenosis? Well, we can't really establish a cause and effect, but we have been able to demonstrate some associations. So the first is macrolide antibiotic exposure in the first few weeks of life. That could be azithromycin or erythromycin. Maybe erythromycin could be used for a promotility agent. Well, those children have a higher risk of getting hypertrophic pyloric stenosis. We also see this is more common in mothers who have smoked, in children who are bottle fed, and there is a genetic predisposition where identical twins have about a 200-fold risk of having pyloric stenosis if one twin has it. And we see about a 30-fold increased risk in siblings. If one sibling has hypertrophic pyloric stenosis, another sibling has about a 30-fold risk compared to the general population. So let's go back to our 5-week-old infant who has projectile emesis. What is our differential diagnosis? Well, the differential diagnosis is quite broad, and this is why our history and physical exam, and eventually our labs and our imaging is going to be so important. So it could be a duodenal atresia, it could be a duodenal web, it could be malrotation or malrotation with volvulus. It could just be gastroenteritis. We also have to think about liver disease or gastroesophageal reflux disease or adrenal crisis like in congenital adrenal hyperplasia. They can present with emesis and lethargy. And also food allergies or formula allergies. So there are a lot of things on the differential, and I'm going to help you establish those questions in the history, in the exam, and of course with our labs and imaging to get this diagnosis of pyloric stenosis. So what is important in the history? Well, early in the course of pyloric stenosis, we're going to see postprandial emesis, projectile emesis that's non-bilious in a child that's 3 to 5 weeks of age. Typically they're crying and they are immediately hungry after a feed because none of that food is going into the intestine. There may be a family history of pyloric stenosis, and we also have to think about any medications. Were they on a macrolide antibiotic? What is the family history? And when we're considering that differential, does the child have any allergies? Is there any infectious exposure? Could this be gastroenteritis or another type of viral illness? So we also have to ask those questions to prove that those things in the differential are not the cause of emesis. So later in the course, how does the history change? Well, later in the course, you're going to see a tired, dehydrated, lethargic, sometimes even unresponsive infant. I may ask the family, do we have wet or dry diapers? And so later in the course, the baby may have dry diapers because they're dehydrated, they're hypovolemic, and going into perhaps hypovolemic shock because they're unable to take in enough fluid. And so if you were to ask me, who am I more worried about? The baby who comes in crying and angry and really hungry, or the baby that comes in sleeping? I'm much more worried about that baby who comes in sleeping because this could be much later when the child is dehydrated and hypovolemic. So how do we do the examination in pyloric stenosis? Well, one is, and you've heard it before, examining for the olive, the palpable olive. You can actually feel the pylorus through the anterior abdominal wall. Now, I'll jump to that because that's kind of pathognomonic for this diagnosis, or this points you right to pyloric stenosis, but it's actually a fairly difficult physical exam finding to elicit. And it is very difficult in that crying and angry child to feel the pylorus. But if I'm going to feel it, usually I'll put the baby in my arms and I'll gently palpate the epigastrium, just kind of pushing against the spine, and I can feel that olive or that pylorus kind of pop right under my fingertips. Okay, now if I can't feel this and the child's very upset, I'm going to get some imaging and an ultrasound anyway to see the size of the pylorus. But if you can feel this, then this can really start to narrow that differential diagnosis. Of course, in the exam, we also want to look at the baby. So general, color, hydration, alertness, nutritional status, disability, limbs, external support, respiratory distress. We want to feel the fontanelles. Are they sunken or are they full? We want to look at mucous membranes. Are they dry? Are we going to look in the diapers? Are they dry or are they wet? All these things are going to give us a good idea of how this baby's doing. And 3 other things to consider. So we want to check the diaper for stool. If we see a lot of diarrhea, we might be thinking that this could be more of a gastroenteritis or infectious picture. If we look at the genitalia and we see abnormal genitalia, we may be thinking of something like congenital adrenal hyperplasia. And I'll talk about this a bit later, especially if this is a female baby, okay? And then lastly, we're gonna get a weight and we're gonna be able to put the baby on their growth curve and see, are they losing weight compared to their normal growth? This will give us an idea of how long they really have not been without nutrition. So next, after we've done our history and our exam, we're gonna get some labs. So what do labs look like in pyloric stenosis? So you have this fishbone diagram here. We have sodium, potassium, chloride, bicarbonate, BUN, creatinine, and glucose. All right, so what is the typical electrolyte imbalance we see in pyloric stenosis? Well, we usually get, the textbook would tell us, and we see this as well clinically, we get a hypokalemic, hypochloremic, metabolic alkalosis. We can also get a mixed metabolic acidosis. Well, how are either of these possible? Well, let's go through it. So get your thinking cap on. Think about how are we going to get this particular metabolic derangement? Well, first is when we're vomiting, we are expelling hydrogen ions, so that's the acid. We're also expelling a lot of potassium and we're expelling chloride, okay? So that gives us our hypochloremic and our hypokalemic, all right, or low potassium, low chloride, metabolic alkalosis. We're getting rid of the protons because, and we know, and I'm going to show you this equation in a minute, and if you can already guess, see if you can guess what equation I'm talking about. But if we look at the relationship between pH, acid, and base, we know that if we lose, let's say, 7 protons, we're going to have to gain those base equivalents back. And that's going to have a relationship with our pH, and that's going to drive the pH up, okay? So in this case, we started at a bicarbonate of 24, and we're losing protons in our emesis. We're going to gain those bicarbonate ions up, let's say 6 of them, and that's going to present this new bicarbonate at 40 and drive our pH up to 7.5. So that's how this alkalosis starts to occur. So what equation was I talking about? So don't have a heart attack or any nightmares bringing back Henderson-Hasselbalch, but it is important to know that there is a relationship between pH, our base, and our acids, and this is the equation that helps us find out how each of these can change. So as pyloric stenosis develops, we are going to have an increased bicarbonate load that's going to hit the nephron. Now, this is going to overwhelm the bicarbonate absorption apparatus, and I'll give you a link to an article that explains that pretty clearly. But that's going to overwhelm our transport mechanism for bicarbonate. So initially, we're going to lose a lot of bicarbonate in the urine, or the baby will be losing a lot of bicarbonate in the urine. Well, with that bicarbonate, to balance this out, we're also going to be losing a significant amount of sodium, okay? So what happens when we lose sodium? Well, when we lose sodium, we're now becoming hyponatremic, so we're going to be driving that sodium number down, all right? That's going to stimulate, with hypovolemia, aldosterone to be released. Now, when aldosterone is released, that's going to start to clench up and absorb sodium from the nephron, okay, with seeing this blood and filtering our blood. And it will preserve sodium at the expense of now losing potassium. So in metabolic alkalosis now, in the distal convoluted tubule of the nephron, there is a hydrogen and potassium exchanger. And so now, because our pH is increasing and the nephron wants to balance that, okay, we are going to save hydrogen ions again at the expense of potassium. And then finally, when hypokalemia becomes severe, eventually sodium will be exchanged for hydrogen, creating what we call paradoxically acidic urine. Now, why is it paradoxically acidic? It's paradoxically acidic because we are having metabolic alkalosis. So why would we want to get rid of protons in the urine? Well, we're getting rid of protons in the urine so that we can save potassium ions to keep us from going into a cardiac arrest because of arrhythmia or some other negative aspect of having hypokalemia. So that is the process. We get a hypokalemic, hypochloremic, metabolic alkalosis. I took you through the process that's happening in the nephron. Now, this is really important to understand, so I'm going to make sure you have the links and resources you need to really seal this in, because you got to know it. So let's go back to our fishbone diagram for our electrolyte imbalance. Look at that basic metabolic profile. So here is a normal one. You got your sodium, potassium, chloride, bicarbonate, BUN, creatinine, and our glucose. Well, what could it look like in severe pyloric stenosis? So we could be hyponatremic. Sometimes we can even be hyperkalemic or increased potassium. We see the biggest change in our chloride and our bicarbonate. So when it's severe in pyloric stenosis, we often see the chloride less than 100 and the bicarbonate over 30. And then we can see abnormalities also in the BUN and creatinine as the child is hypovolemic and putting pressure on that renal system. So how about imaging? Well, ultrasound is the gold standard. We're not going to see anything on plain x-ray, okay? So ultrasound is the gold standard. When performed by a skilled ultrasound technician and then read by a radiologist, we can get a really confident picture on whether this is or is not pyloric stenosis. So in order to make the diagnosis, we look at two things. We look at the pyloric muscle thickness and the pyloric muscle length. For a diagnosis of pyloric stenosis, we want the pyloric muscle thickness to be greater than equal to 4 millimeters, and we want the pyloric muscle length greater than 15 millimeters. Looking at the images here, we have a sagittal section of the pylorus in a baby with pyloric stenosis, and we can see a thickened pyloric muscle, so the PMT is 5 millimeters, and we also see an elongated pyloric muscle length here at 18 millimeters. So with the history and exam, we can make the diagnosis of pyloric stenosis. So now we're going to talk about treatment. So is emergency surgery necessary? Absolutely not. Pyloric stenosis is not a surgical emergency. Pyloric stenosis is a medical emergency. Okay, so what does that treatment plan look like? So to treat pyloric stenosis means getting adequate IV access and beginning volume resuscitation. We begin with a 20 ml per kilo bolus of normal saline, and we start a maintenance rate of D5 half normal saline without potassium at double the maintenance rate. Now, as long as the potassium level in the BMP is normal and the child is voided, then we can add back in, for instance, 20 milliequivalents of potassium into that maintenance fluid. But we usually start with D5 half normal saline. It's important to know that additional fluid boluses may be necessary, especially in those kids with very low chlorides and very high bicarbonates who have had emesis and pyloric stenosis for a long time. The last bullet point I want to say is no NG tubes. So if we put an NG tube in to decompress the stomach, we're going to be pulling even more electrolytes out of the baby and can further that electrolyte imbalance. So a nasogastric tube is not necessary. One resource that I want to talk about is there is a fantastic pyloric stenosis clinical pathway that Johns Hopkins has put out. I'll put a link to it in the description, but we'll go over it quickly. And you can see in this algorithm, they have some decision-making steps by what the chloride and bicarbonate levels are. We can start to think about our fluid replacement strategy and when we need to repeat our basic metabolic profiles so we can get that child ready for surgery. So definitely read this. I'm going to put a link into the description below and have a look at that algorithm there. So in order to go to surgery, what do we need? Well, we need a resuscitated baby, okay? I like to see the urine output at least 1 to 1.5 mils per kilo per hour. And we also need to recheck that basic metabolic profile, see that our numbers have come back to normal, and especially that our chloride is over 100 and our bicarbonate number is less than 30. Why do we want that? Well, if we have severe metabolic alkalosis and we go to the operating room, bad things can happen. We can have cardiac arrhythmias. We can have respiratory depression. So what does the body want to do when we have a metabolic alkalosis? How does that affect our respiratory centers? Well, our body is going to want to create a respiratory acidosis to balance that metabolic alkalosis, okay, and get our pH back to normal. Well, how does it do that? How do we get a respiratory acidosis? Well, we stop breathing, okay? If we don't breathe, then we're going to increase our CO2 levels, and that can start to create that respiratory acidosis. Now, on the operating table, that can have a baby that we can't wean from the ventilator. So that's one reason that we want that bicarbonate to come back to normal. So if we've resuscitated the baby and now we've achieved our parameters to go ahead and go to the operating room, we have a couple of choices. We can either do an open pyloromyotomy or we can do a laparoscopic pyloromyotomy. If we do an open pyloromyotomy, we can do an upper transverse incision, we can do a midline incision, or we could do an incision that is around the umbilicus. It has a little bit better cosmetic effect if indeed we are going to do an open pyloromyotomy. Now, technology and skill advancement has allowed us to do this laparoscopically, and I'm going to take you through some images here. In a laparoscopic operation, we can see our incisions. Well, you can hardly see them. So you have one in the umbilicus, and that's where I'll put a disposable trocar, okay? Usually a 3 millimeter disposable trocar, and I'm going to use a 2.7 millimeter laparoscopic telescope and a camera, all right? And then on the anterior abdominal wall, you can see two little Dermabond or glue spots here. This is where I'll do stab incisions to place my 3 millimeter instruments. And what do I see when I get inside? Well, the first step is to expose the pylorus. Now you can see a thickened and enlarged pylorus here, all right? So it is white, it is large, it's tense, and it's quite hard when you go to grasp it, all right? So I'll bring this into the field. Once I have the pylorus exposed, I'll grab the duodenum gently with my left hand with a slotted grasper. Keeping the pylorus in the field, I'll make a transverse incision across the pyloric muscle with a Bovie electrocautery knife at an energy of 10. Once I'm able to divide the muscle for a couple of millimeters, I'll then put in a special device that's a laparoscopic pyloric spreader, and I'll be able to spread that muscle, and it will spread all the way across the pylorus. And ultimately, the operation's complete when I have a nice spread all the way across the pylorus. I'll feel the shoulders, make sure that I've spread up to the shoulders of the pylorus, okay? Then I can grab each leaf and move them independently. Now, if I can do that, move those independently, then the operation is complete. Now you can see here that I've divided pyloric muscle, but I have not entered the mucosa. That mucosa you can see is bulging at the base of the wound, and that's what we want to see in a pyloromyotomy. Now, laparoscopic versus open, which is best? A few years ago, the team at Mercy in Kansas City did an awesome randomized clinical trial where they looked at laparoscopic versus open, and these are nearly equivalent. Okay, they're equivalent from a safety point of view. The babies that get a laparoscopic operation have a little less pain, a little less need for postoperative pain medication, and may have a shorter time to full feeds, but the difference is really just hours. So the right operation is the operation that's the most comfortable for the surgeon performing it. Now, how do we manage these babies postoperatively? Well, as soon as the baby is awake enough to feed, we can feed with formula or hopefully breast milk, all right? And we'll initiate feedings and let that baby feed ad lib. So feed as they are able to feed. Now, we used to do a very protocolized, quite complicated feeding advancement regimen where we would start at a ½ ounce. And if that was tolerated, we go to an ounce. And if that was tolerated, we go to an ounce and a half, up to 2 ounces. And then if the baby puked, we would go back down. And this took a long time. And so the modern approach is let these babies feed. They may vomit, but ad-lib feeding protocols have been shown to get babies home quicker, and that's also one of the things that we want when we're managing these babies in the hospital. I have put a reference right here. You could check out this recent paper in Ped Surgery International, which supports that ad-lib feeding results in a shorter hospital stay duration compared to a protocolized feeding schedule. And I'll put the links to this paper as well as some others like it out there so you can get comfortable with this data. The final thing that's important to talk about is, well, what are the risks of surgery? Well, the risks of surgery are several. You can have an incomplete myotomy. Now, this is true whether it's laparoscopic or open, okay? So an incomplete myotomy, the baby will not be able to feed. Now, vomiting is common postoperatively, and we can usually just feed through it. But if it's been 5 to 7 days after the procedure and the baby's still not tolerating feeds, often we'll have to get an upper gastrointestinal contrast study to see if the stomach is emptying, and if it's not, the baby certainly may have an incomplete myotomy and need a repeat operation. A second risk is mucosal perforation. So when we're splitting that muscle, whether it's laparoscopic or open, okay, and the risk is the same, it's very rare, but there is a risk of injuring that mucosa. Now, if that mucosa is injured, the teaching is that you close the mucosa, close that myotomy, right, and then turn the pylorus 180 degrees and repeat that pyloromyotomy. So the last three risks, the first, aspiration. So remember that stomach has been unable to empty. So we want to empty that just before we do our endotracheal intubation. Second is a risk of wound infection. And then of course there is a risk of getting a hernia at the incision site or at the port sites. But again, that's quite rare. All right, so today we talked about pyloric stenosis. This is a common thing that I see as a pediatric surgeon. And I hope that going through everything today got you fairly comfortable or at least inspired you to do some more reading. I'll make sure that all of the resources today are down in the description, so check that out. If you haven't had a chance to subscribe to the channel. That's how I know you're finding value here. We're gonna get some more pediatric subjects coming out in the next few weeks, and I'm pumped about it. As always, study hard, stay safe. I'll see you in the comments, and I'll see you next time.